Welcome to Addressing Racism in Medical Research and Publishing. This is the fourth and final event in a series of online discussions for journalists this fall, produced by the Hastings Center in partnership with the Center for ELSI Resources and Analysis, CERA, a federally funded project that builds the community of researchers focused on the ethical, legal, and social implications of genetics and genomics. We are pleased to be joined by Vabren Watts, the Equity Director of Health Affairs, Mildred Cho, professor at Stanford University, Associate Director of the Stanford Center for Biomedical Ethics, Director of the Center for Integration of Research on Genetics and Ethics, and co-PI of the CERA, and Fernando de Mayo, Director of Health Equity Research and Data Use in the Center for Health Equity at the American Medical Association, and Professor of Sociology at DePaul University. We hope for strong participation from the audience. Please type questions in the Q&A box at the bottom of your screen. You can also use the chat function to share relevant resources. This event is being recorded and will be available on the Hastings Center's website later today. It will also be available on the CERA's website, ELSI Hub. Now I would like to introduce Susan Gilbert, Communication Director of the Hastings Center, who will say more about the annual journalism discussion series.
Thank you, Ashna. Hello, everybody. The Hastings Center is a bioethics research institute that produces scholarly analysis and policy recommendations on a wide range of ethical questions in health, healthcare, and the life sciences. In addition to our research, we have an equal commitment to public engagement. This year, the Hastings Center launched an annual event series that we call Bioethics for Journalists. It is a set of discussions to help journalists identify ethics questions, and pursue investigation of those questions on emerging topics in health and science. The series is part of the Hastings Center's Callahan Public Programs, named for our co-founder, Daniel Callahan. It is an initiative established and supported by the Andrew and Julie Klingenstein Family Foundation and the John and Patricia Klingenstein Fund in honor of Dan. I'd like to express deep appreciation to the Klingenstein family for their vision and support. The theme for this year's series is Genomics in Society, New Developments, New Questions. We are fortunate to collaborate this year with the Center for ELSI Research and Analysis, a project led at Columbia University by Dr. Sandra Sujin Lee and at Stanford University by Dr. Mildred Cho, who is one of our panelists. Dr. Cho is also a newly elected Hastings Center Fellow. Many thanks to the CERA for this partnership. Today's event is on racism and unconscious bias in medical research and publishing. Researchers and journal editors are reckoning with this longstanding problem. Journalists who write or aspire to write about medicine look at journals for story ideas. The editors of those journals have an indispensable role in identifying and eliminating racism in the review and publication of research. What anti-racist steps are leading journals taking? What more should be done? What kinds of cues can help journalists recognize racial bias in a research article? It is my pleasure to introduce the moderator, Vabren Watts, the Equity Director of Health Affairs. In addition to being the leading journal of health policy, Health Affairs has taken a lead in addressing racism and promoting equity in journal publishing. Dr. Watts was hired to help move these efforts forward. A former journalist, he has a background in research, science and health communications, and diversity, inclusion, and equity strategy. He has a PhD in pharmacology. Welcome, Vabe.
Hi, how are you? I had a little problem there trying to turn the camera. Thank you so much, Susan, for allowing me to speak at this session. You know, as Susan said, you know, I come here actually from two different angles. One as a science and health journalist, and another as a strategist for diversity and equity. As Susan said, you know, in 20, I actually came to Health Affairs to actually lead their diversity and equity initiative, known as Advancing Equity in Research. And just to give you just my thought process, I'll put it that way. When I came into Health Affairs, I just want to share some things with you, what we're doing and how we landed to where we are today as it relates to advancing equity. And you all know that, as we open with, scholarly publishing is very important. In academia, they have a series, like publishing a series of articles is often a factor that, increases like a lot of things, your likelihood of tenure, your likelihood of grant. It's that whole publish or perish model. And it really positions you as an expert in the field, as well as makes you, more competitive for jobs, for promotions, and as I said, as grants. And it brings, not only recognition to you, but also recognition to your organization as well. So it's very important. So, however, there are disparities in scholarly publishing, and that is a broad term when I say disparities in scholarly publishing, because there's many different types of disparities. One type of disparities is, I would like to say, is funding disparities by institutions. Institutions with more research dollars are more likely to repeat publishing in high quality or high impact journals. For instance, some of the top funded research institutions are the top publishing institutions within Health Affairs. And then we also look at gender equity within scholarly publishing, where women are less likely than their male peers to publish. Almost half as likely, from data, I would say, at the beginning of 2020, when the pandemic set in full throttle. Actually, it is prediction that this disparity gap has actually increased due to demands by women, at their home life, as we, were in quarantine. They had responsibility. It's assumed that they have more responsibilities at home that sort of kept them from focusing on publishing and things like that. And then third is what I'm going to publish on today is really talking about racial disparities. Racial and ethnic minorities are actually 10 times less likely than their white counterpart researchers. And keeping that in mind, I'm just going to go over like some of the reasons for racial inequities in scholarly publishing. And we're first going to start upstream of publishing. Racially biased practices is one, either consciously or unconsciously, that often permeates organizations within the U.S. And as I said unconsciously, because I really do believe that for the most part, racial bias is unconscious. It's just that, unfortunately, within the U.S., there has, been a foundation laid years before us, hundreds of years before us, that actually still permeate into our systems today. And so this results in lower rates of research funding awarded to racially underrepresented researchers, hindering executions of research plans by those researchers of color. Racially underrepresented researchers tend to propose research topics with lower award rates that focus on community and population research versus the more fundamental and mechanistic investigation that tends to have higher award rates. And then we also have to play we also have to consider that there's sometimes also a lack of mentorship or collaboration offered to racially underrepresented researchers at their institutions, particularly those institutions where you may not have that many researchers of color. Now, I just named the reasons for racial inequities in scholarly publishing. And I will say, at that point, I did talk to, speak with my boss about this. I said, well, those are some things that we cannot control, because, when it deals with addressing racial inequities, you have to control those. You have to tackle those things that you can control. And, you know, if everyone along the pipeline, you know, starting like from grants, I know the NIH has programs where they're looking at, you know, racial equities and grants. And then we're one of the first journals to really look at racial equity as it relates to just within peer reviewed publishing. So, you know, in order to do this, we had to, you know, notice some things or recognize some things that are going on. And so at the level of publishing, you may have rejection of manuscripts that use non-standard methods for interpreting research outcomes. Different cultures have different ways of publishing methods and interpreting research across disciplines. You may have lack of diversity among reviewers and editors. One of the things that we currently just completed at Health Affairs was actually a survey on a racial demographic survey and gender survey of people who submitted to the article, to the journal over the past 3 years, and really, you know, asking us, is our demographics actually, you know, racially diverse? And when we ask authors to review, is that also diverse? Because we know that in certain situations, reviewers who identify with, I would say, a particular race or gender can sometimes pinpoint things in research that may be a little controversial or just need really a deeper dive to explain why they came up with that answer. At the level of publishing, you know, it isn't like, as some people say, we really looked at, you know, do we have enough outreach to researchers of color and minority affirming institutions that includes like our tribal colleges and universities, our historically Black colleges and universities, as well as our Asian American and Pacific Islanders University. And then you also we have to look, you know, internally, just introspectively, you know, and notice that research shows that, you know, there is a lack of diversity among those employed by scholarly publishing firms. Actually, research was done by the Urban Journal Library in 2016, which showed that around 90% of editors of peer-reviewed journals actually identify as white. And then, you know, just then most journals have a lack of data on demographics of authors, reviewers, and editors. And as I said earlier, that's something that we just tackled with our survey. And we're making moves to actually do other things to actually address this, which I'll get into later. So, so where there is racism, only anti-racist systems can generate equitable results. That's from our editor-in-chief, Alan Weil. And so in 2020, we received funding from the Colorado Health Foundation, as well as the Robert Wood Johnson Foundation, to really look at equity, racial equity, and propose a strategic plan to really advance equity in scholarly publishing. And we did this really focusing on three things, and I'll just quickly go over those with you. One was on equitable participation. We are a journal, and you know, you think of journals, you think of authors, you think of reviewers, you think of editors. And so, you know, in equitable participations, we're looking at, you know, if our authors, reviewers, and editors are diverse. So, you know, really increasing that based on race, ethnicity, and other identifiers such as gender. And we have been implementing this, and you know, we are currently doing outreach to researchers of color for submission and review. We are building relationships with minority affirming institutions, with health services research programs, because we are a health services and health policy peer review research journal. And then also develop mentorship programs for equity researchers of color to expose them to health affairs and guide them through the publishing process of the journal. And I will say that I'm proud to say that we just actually selected our first cohort. And during our first application cycle of our health equity fellowship for trainee programs, which is for young scholars of color. We actually had 55 applicants, and we selected 10 new fellows who would be coming in January to really publish in our journal, and they will have multi-layered mentorship, which really includes mentorship from health affairs authors who have published at least twice in the journal, as well as mentorship from the editorial staff at Health Affairs. Also, we are really focused on new voices, and that is incorporating health equity research or program outcomes from institutions or community-based organizations that have been historically not well represented within our journal. And that is forming partnerships with professional societies and programs that focus on advancements of health services research, partnering with those community-based organizations that have programming intended to increase health equity and really expand promotion and marketing, particularly of health equity products, to those entities that target health service professionals and those communities of color. And then I'll always say this: when you look at diversity, equity, and inclusion strategy, there's actually two things that's going on. I would say the easiest will be the external, which is the first 2 points that I made. And one of the hardest is actually the introspection, and that is addressing our own biases as part of a publishing enterprise. We have several things underway. One of those things include bringing in actually researchers of color who not only do health equity research, actually who we've had in the past did not do health equity research, but really just exposing the staff, as well as exposing those researchers of color to health affairs that do health policy and health services related research. And it has been interesting thus far, because those people who we have invited have actually sort of come into the fold of health affairs by serving as reviewers and really expanding our resources for expertise on certain topics and issues, and just making sure that we are getting perspectives from everyone, regardless of age, race, gender, and ethnicity. So some of the projects that we completed that I went over, we did do an assessment of content. One of the things that when I came in, I did say that but before we start, let's see where we are now. I will say Health Affairs, 11% of our journal content over our 40-year history does reference equity with respect to race and or ethnicity. The second half of 2020, we had more than 45% of papers published related to race and ethnicity, which that can probably be explained because that really the midway point of 2020, that's where racism did play a huge part. It was a popular conversation rather at the end of 2020. We will also, starting January 1st of 2022, we will start tracking race, ethnicity, and gender among authors so that we can continually see where we are as it relates to incorporating those voices and getting engagement from diverse populations. And then we had to do a formation of an equity advisory committee to really help guide health affairs with advancing racial equity and to make sure that we are meeting the needs of the community of researchers that we serve. So with that, just to give you just the impact of advancing equity through scholarly publishing, it is just, regardless of how a researcher self-identified, the impact of publishing a health equity related manuscript in health affairs is more than just a professional accomplishment. It means that a researcher has identified an issue or a successful method to advance health services that is critical in informing care to the general public or specific populations that are most burdened by failures in the U.S. health system. And I'm trying to take stop sharing. Okay. All right. There I am. Yeah. So with that being said, it's only things that, we can do in the field of scholarly publishing really to vet the research that come through. But however, we get, Health Affairs gets over 7,000 submissions per year. So some things go missed. But I will say, as speaking from a journalist, it's just like you just really have to really critique, each, manuscript that comes across your paper that you want to turn into an article to make sure that the information is accurate. Because I know as a journal that sometimes the information can be controversial, and and we really have to scrutinize data before we publish it. So I am going to move the program along with Fernando de Mayo, Dr. Fernando de Mayo, who is with the American Medical Association, who I will say also, I had the pleasure of sitting on a panel with him, and he's actually submitted a blog post, which was published in April 2021 in Health Affairs, that actually talked about the use of the term racism in medical literature, which was an awesome paper. So that's just the pub. If you have not read that paper, please view it. It's in Health Affairs, April 2021. Without further ado, I will introduce to you Dr. de Mayo.
Great. Thank you so much, Dr. Watts. It's a pleasure to see you again. And a huge thanks to the Hastings Center for bringing us together for this important conversation around racism in medical research and publishing. So as Dr. Watts mentioned, I'm Fernando de Mayo. I serve at the American Medical Association as Director of Research and Data Use, and my academic appointment is at DePaul University, where I'm a professor of sociology and teach social epidemiology in our public health program. I want to show just a few slides to contribute to the conversation, and I very much look forward to the question and answer period of the event. So I want to begin with a very old example, probably the oldest data you will see today. This is from 1926, a piece that I republished in a book called Community Health Equity, a Chicago Reader, which I edited with some fantastic colleagues, Ross Shaw, John Mazzio, and David Ansel a few years ago. So this was the Chicago Tribune, 1926. The broad headline from a well-intentioned journalist: "This is the world's healthiest city." And the journalist reported data that had just been published from the public health department, showing that Chicago had the lowest death rate per 1,000 people. It's kind of small, it's in the red box, but it had the lowest death rate per 1,000 people compared to Berlin, New York City, Vienna, Philadelphia, my home city of Buenos Aires, and Paris. And then they also added Bombay and Calcutta as reference points. But this was the headline: "This is the world's healthiest city." And the story concludes that to live in Chicago is a safeguard. It's a form of life insurance, but has certain advantages over insurances and costs nothing extra, and everyone benefits during his own lifetime. And I'm sharing this example because the remarkable thing that happened the following year. A sociologist named H.L. Harris published this remarkable piece in the American Journal of Sociology, saying that the headline was true, but only if we looked at aggregate deaths. Right? If we looked at Chicago death data overall. If we disaggregated between Blacks and whites, a profoundly different story emerged. This was not published by the public health department in the original report. It was not captured by the journalists in the Chicago Tribune, but it was unpacked, right, in the conversation the following year by Harris. The white rate was lower than in the other cities. The Black rate was profoundly high. And that's the story that we've been retelling over and over again for decades ever since. And in many ways, it's the same story that I told in this book called Unequal Cities, which I published earlier this year with Maureen Benjamin at Johns Hopkins University Press. I want to show you a little bit of the data and then kind of unpack what it means in terms of our understanding of race versus racism as a determinant of health inequities. So you'll know that across the United States, our life expectancy on average for everyone combined is in the high 70s, 78.6 in this time period of 2013, 2017. Of course, now we know that this has taken a hit as a result of COVID. But what we don't know, because we typically don't present data in this way, is the 10-year gap that exists just on average, on aggregate, between our healthiest and least healthy cities. Between San Francisco and San Jose, where life expectancy is in the low 80s, 82.9, and Baltimore, Maryland, where life expectancy on average is 72.9. Just like Harris did in 1927, we disaggregate the data by race, looking at differences, broad differences between Blacks and whites, the 4.4-year gap across the United States. And for us, really important, the variability across the cities. So the 12-year gap in Washington, DC, and the negligible Black advantage in life expectancy in El Paso. Boston, Jacksonville, San Jose have far smaller gaps than my home city of Chicago, where the gap is over 8 years. Now, there's nothing natural about this, and understanding the dynamics, the variability, how this varies across places and also across time, for us is really profound. And it gives us a sense of the local and state policies that drive these inequities. A bit more data. Across the country, we can look at the all-cause mortality rate ratio. If things were equal, if things were equitable, we would have a one-to-one relationship between the Black and white rate. Overall, the Black rate is 23% higher. The rate ratio is 1.23. And it varies, just like life expectancy did, it varies across cities, where the gap in Washington is more than 2 times higher than the white rate. This culminates in probably the most important metric that we try to communicate, that have been picked up by journals in different settings on excess deaths, right? The number of people every year who die prematurely as a result of inequity. So this varies across city, and it's a function of 2 things: the relative gap between the 2 groups and the size of the Black population. So again, my home city of Chicago here fares worst of all in the analysis. And again, this is a story that is kind of echoes across time, both in the academic space, whether it's in books or articles, and there's lots of examples that we can come across, and also in the journalist space. So this was the cover of the Chicago Sun-Times. Healthcare gap kills 3,200 Black Chicagoans a year, and the gap is growing. This was from 2009, based on a study published by Maureen Benjamins and the group that I collaborate with. So our deep challenge, both as researchers, medical professionals, public health professionals, journalism, is how to advance this story. So it goes from describing problems, describing inequities, to really understanding the sources of those inequities. Because we could have, and we have, lectures full, books full of how race and racism manifest in health inequities, right? So the same story could be told for heart disease mortality, breast cancer mortality, stroke, all of the major killers in society. Our challenge, we think, is to tell a deeper story about these downstream effects, these mortality indicators, whether we're looking at life expectancy or infant mortality or cause-specific mortality like cancer, heart disease, stroke, and so on. But really track upstream, right? Going beyond stories that look at differences between people based on their risk behaviors and individual beliefs and behaviors, to looking at the living conditions, what increasingly are called the social determinants of health, the characteristics of the places in which we live, work, and play. But then even further upstream, right, to the root causes of these inequities. And this is where we get to far more difficult things to measure, right? White supremacy, racism, classism, sexism, homophobia, ableism, xenophobia, and more. So this is where we think, and they've mentioned this before, this is where we're seeing a remarkable challenge being raised in medicine and public health. So with Rhea Boyd and Nancy Krieger and Aletha Maybank, we did these 2 analyses. That one came out in Health Affairs blog, and the other came out in Time. The world's leading medical journals don't write about racism, and that's a problem. And it was based partly on our own personal experiences, having gone through the publication process in different places, in different contexts, and then also hearing about the stories that our colleagues had also experienced. So we tried to do a very simple descriptive task, and we looked into the literature. So we saw a dramatic increase in the number of articles that just include the word racism in 2020. right? A huge explosion in the British Medical Journal, in the Journal of the American Medical Association, New England Journal of Medicine, and The Lancet. All saw an explosion of papers in 2020. And the same with our kind of comparison, the American Journal of Public Health, which had a longer history of publishing articles that even just mentioned the word racism since 1990, but did also see a remarkable increase in 2020. But when we look deeper into what was happening within the medical journals, and this kind of reinforced our own experiences, we found that the vast majority of the papers that even said the word racism were really viewpoints, commentaries, and kind of opinion pieces, op-eds. The empirical papers, the science, right? The data-driven papers with an introduction, method, results, and discussion, very few of them actually used the word racism, even in the discussion. And a small, very small minority, you can count them on your hand, actually had them in the methods or the results. That is, incorporated the data, the science of the study of racism in society. And we think this is really important, and we applaud and celebrate health affairs efforts to try to overcome this in the future. Our article concluded like this, that if we as medical and public health professionals cannot name and confront racism as a root cause of racial health inequities, it profoundly affects what the broader public knows and doesn't know about the racial distribution of health and disease and its social causes. It is past time for the world's leading medical journals to name racism, publish evidence on how racism harms health, and articulate how dismantling racism can prevent racial health inequities. And one of the tools that we've developed to try to do this, right, to try to move this forward, is this new guide that we just co-published between the AMA and the AAMC Center for Health Justice, Advancing Health Equity, a Guide to Language, Narrative, and Concepts. It's structured into 3 parts. The one is about language, the second is about narratives, and then the bulk of the document, which I think is about 54 pages, the bulk of it is actually a glossary of key terms, providing accessible and we think helpful definitions of more than 140 key terms and concepts that are frequently used in health equity discussions. It was supported with a piece from our AMA president, Dr. Gerald Harmon, noting that our words matter, it's time to get them right. And it was meant to be not an act of language policing, right? It's meant to be a guide. It's meant to be a resource to push our understanding and awareness of how words, language, and the underlying narratives influence our work, both as researchers, as authors, and potentially for you as journalists as well. You will have undoubtedly seen that the reaction to it has been quite negative in many quarters. It initially started in very right-wing websites like InfoWars. You can tell they didn't like the document because both health equity, racism, and white supremacy were in quotes in their title. But it also was mirrored in many of the critiques raised in the Washington Post, the New York Post, and the Atlantic, and then further in Fox News and other places. So for us, this is a really important conversation to have, even if it's uncomfortable for many people, recognizing that our very capacity to understand racism in society is deeply impacted by our comfort with language, right? And so for us, this is really important. So all of our phrasing, race relations, racial chasm, racial justice, racial profiling, white privilege, even white supremacy, serves to obscure that racism is a visceral experience, that it dislodges brains, blocks airways, rips muscle, extracts organs, cracks bones, breaks teeth. Ta-Nehisi Coates advises to never look away from this. You must always remember that the sociology, the history, the economics, the graphs, the charts, the regressions, the language, right, all lands with great violence upon the body. So we see this in our population health indicators, and we're trying to develop better tools by which we can acknowledge the social construction of race, right, decrying racial essentialism. In fact, we have new American Medical Association policy officially acknowledging the social construction of racial categories and officially moving for the end of the use of race in very simplistic ways in medical algorithms, right? Moving away from that and moving towards a deeper understanding of racism as a root cause of health inequities. Right? Race is not a risk factor, but racism is a root cause of health inequities that we see across our population health indicators. And perhaps the last word that I'll mention comes from Dorothy Roberts, who we feature in our Advancing Health Equity Guide. She notes that race is not a biological category that naturally produces these disparities because of any kind of genetic difference. Race is a social category that has staggering biological consequences because of the impact of social inequality on people's health. And she gave this charge. What if doctors join the forefront of the movement to end the structural inequities caused by racism, not by genetic difference? The very first data that I showed you, the life expectancy variability between Baltimore and Washington, Baltimore and San Francisco and San Jose, that cannot be explained by any genetic model, right? This is the story of structural racism as lived experiences in our cities, as manifest, right, in the history in which we carry in our bodies. So for us, this is a really important and critical area of research and scholarship and conversation that we want to have, not just as an academic research community, but as a broader community with journalists and readers of all kinds. So I think I'll stop there. And I know we have a fantastic rest of the panel coming up.
Thank you so much, Dr. De Mayo. First, for just all the wealth of information that you gave, and thank you for everything that you're doing. I would now like to turn it over to Dr. Mildred Cho, who is a professor at Stanford University. She is the Associate Director of the Stanford Center for Biomedical Ethics and the Director of the Center for Integration of Research and Genetics and Ethics.
Thanks, Vabe. Let's see if we can share the screen here. How does that look for everybody?
Yes.
Okay, so thank you for inviting me, Susan, in the Hastings Center. And as Susan mentioned, I am a co-director of the Center for ELSI Resources and Analysis, but I'm also speaking here today informed by the work I've done as an editor on the editorial board of the journal Genetics in Medicine. And I think what Vabe and Fernando have talked about is a nice lead in here, because I think it really highlights, those previous two talks highlight how race and ethnicity and racism are used differently in different fields like public health, like health services research, sociology, and also clinical research, genomics research, and biology. And I think one of the things I'd like to do is encourage us to really drill down and be aware of these differences as people who are involved in publishing and writing about race, ethnicity, and racism, and also question and examine these variables as scientific variables. So as you know, we use race and ethnicity in medical research all the time, but it is useful to think about why and question, why do we use these categories? And part of the answer is that we've always done that. It goes back, it's a tradition now. But based on this idea that the differences between racial and ethnic groups can reveal differences in disease frequency, drug response, and all kinds of things, diagnostics and therapy. And so we use these categories to guide treatment and diagnosis. And I have a quote here from an article that is making this argument. In response to this, I wrote a paper back in 2006 in response to the argument that we shouldn't throw the baby out with the bathwater, we shouldn't get rid of race. And while I would argue that it's not racist to use racial and ethnic categories per se in biomedical research, if it's not done properly and without adequate justification and examination of how it's used, it can be racist. And so I would like to argue that the differences between groups is not what is in question. There are clearly differences between groups, no matter how you slice the groups. But the question is whether those differences, and if they're clinically significant, do they actually map onto racial and ethnic boundaries, however they are defined?
in addition, I would also like to point out that it is very difficult, if not impossible, to actually identify a sort of consensus or a single accepted set of racial and ethnic categories. We usually can't even define what race or ethnicity means. And so this makes these variables very difficult to deal with in a scientific context. They're very imprecise and non-scientific. And I would argue that we use these categories in ways that we do not allow ourselves to use other kinds of categories or variables in science. And so this, and also I think what's dangerous and what I think Vabe and Fernando alluded to is that relying on racial and ethnic categories can, if used improperly, distract from other information that might actually be more relevant to the research question, or such as environmental factors or social factors, including even racism. So I just want to point to some articles as references, and I have a list of the references for people to refer back to later if you want to get the full citations for these. But there are many different attempts now at dealing with racism and race and ethnicity in medical publications. This one is one that I wrote with co-authors who are also on the editorial board of the journal Genetics and Medicine, Kyle Brothers and Robin Bennett. Research groups are also issuing guidelines on use and reporting of race, ethnicity, and ancestry in genomics research and precision medicine, as well as biomedical research more broadly. I just wanted to mention that the work that we did for the journal Genetics and Medicine was very influenced by this article written by Rhea Boyd and colleagues in 2020. So don't worry, all of these references are here. And so I just wanted to talk about what's at stake here. There are lots of things at stake. One of them is overly focusing on race as a marker of, for example, drug response. So in this quote from an article that I mentioned in the previous article that I had mentioned that I wrote, it talks about differences between Europeans and Japanese in loss of function variants in a locus responsible for metabolism of drugs. But then later in the paper, although you would then sort of conclude that European versus Japanese ancestry might be associated with drug metabolism and thus guide pharmacogenomics. Later in the paper, they talk about a similar level of variation even within Europe. So from people from northern Spain versus those in Sweden. So it pays to be careful about how you interpret these kinds of results. Many people have also written about how misdirection of attention to race can be caused by focusing overly on racial categories as opposed to disease state or symptoms or other kinds of categorizations like nationality. So for example, the highest rates of sickle cell disease are in some areas of Africa, although there are also areas of Africa, including Western Africa, which have relatively low rates of sickle cell disease or trait, but very high areas in some parts of India, Sicily, Greece, or southern Turkey. So if you focus overly on Black race or African Americans in the United States, you could easily be missing a diagnosis of sickle cell disease. Another issue is that the racial and ethnic classifications and the way we ascertain them lead to huge inconsistencies. And so I just give you some data from an article that was written 20 years ago, a study of US Census data of those that indicated Indian ancestry or birthplace in India on the census. 10% of those identified themselves as white Black, or American Indian, despite instructions directing them to the Asian Indian category. Those who spoke English only were associated with higher likelihood of self-identifying as white or Black as opposed to Asian. And those of Indian national origin were more likely to select Black, while those of Sri Lankan or Pakistani origin were more likely to select white. 80% of children with one white and one Asian parent in the census were listed as white. So you can see that how inconsistent these categories can be, even by self-report. Another example of the inconsistency is in comparing visual identification by police in the United Kingdom with predicted classifications by genetic analysis of STRs at loci, and they were only consistent 67% of the time, so 2/3 of the time. And the classification by this kind of analysis as Middle Eastern by genetics was consistent with the visual identification by police only 30% of the time. So again, another example of how we are not even sure. It really depends on how you ascertain these variables in terms of what answer you get. So what can journals and writers, authors, researchers, editors, and others do about this? There are many things that Vabe has already mentioned, that the Journal of Genetics and Medicine has already initiated, including encouraging authors to examine their citation practices. So as Vabe mentioned, there are huge disparities in publication by race, but also in terms of who gets cited. But another thing that we're trying to do at the Journal of Genetics and Medicine is really think about how to get reviewers of journal articles, since they are the gatekeepers of publication in biomedical journals, to really shift their thinking on how they review. And so we are trying to think about providing reviewers with training on how to review not just the language that is used in the manuscripts that they review, but study design, methods, the claims, the limitations throughout the entire article. So for example, is the use of race or ethnicity even justified as a variable? We do it as a sort of knee-jerk reaction. We think we're required to do it, but maybe we're not. Maybe race or ethnicity really has nothing to do with the study that is being done, and the inclusion of it does imply that it is important, and also can imply that it is a biological variable. However, using race or ethnicity as a biological variable is highly problematic, as many people have argued and given examples of. And also it is important to question whether there are other important variables that were not studied that are likely to be associated with or even a cause of conditions that are in question. And finally, something that can be done by journals that goes beyond the reviewing process is to encourage authors to engage in research that engages racism as a subject of study, and then publish it. Vabe also mentioned this and spoke about how his journal is working on this issue. And part of this is also a re-examination of how articles are prioritized for publication by really rethinking what we consider to be novel or significant. So at the Journal of Genetics and Medicine, we actually rewrote our mission statement because it implied that articles that were examining questions that may have been asked in populations such as white populations or European populations would not necessarily, or that did not use those populations would not necessarily be prioritized if the answer if the research question had already been asked in a white or European population, and therefore would not be considered novel because it would be sort of not a new research question and therefore not significant. And so the journal has rethought that stance in order to encourage researchers to broaden their sampling to understudied and underrepresented populations, which we all know are highly problematic in terms of the conclusions and the clinical implications thereof. So I will stop there and think we can get into the discussion.
Yes. Thank you so much, Dr. Cho, for that information. It was very eye-opening and a lot of things that I have not viewed before. Or thank you for that data, and thank you as well, Dr. De Mayo. Before we go into questions from the audience, it was some questions that I would like to ask. So I would just like to ask the audience to start submitting your questions now. But before we go into it, just some questions, some things I wanted to touch on, and this question is for either one of you, because both of you touched on this. How much do politics and the political climate affects efforts to address racism in medical research and publishing?
Happy to go first on a very difficult question. Yeah, it has a huge effect, right? And you can think of the political climate in very different ways, though, at a national level, at an institutional level, at a disciplinary level, right, within your own community of scholarship and work. And all of them intersect and interact in important ways. But I think what we're seeing also, even in the most difficult climates, in the most stifling climates in terms of creativity and forward-thinking research design and language, there's always moments of resistance, right? Of change. There's always opportunities to reflect and refine our methods, to question the assumptions under which we operate, whether it's in terms of research design, the racial categories that Mildred just spoke about, the statistical techniques that we use to look for differences between groups, and the very language that we use, the framing of our questions. There's always opportunities to do that. I think moving forward, that's one of our most important challenges, right? To strengthen, regardless of the political climate, the opportunities for reflection and refinement and improvement. Because all of our work can always get better on these points. There's all kinds of assumptions that we take for granted that we carry on with us in the very way that we think of our research questions and the way that we write up our results. So that's an ongoing challenge.
And we'll piggyback off that. Something that you said that sort of struck me. We're at a point now, and I always think about this, I'm sure all of us do. We're at a point now where racism was in the forefront. And what can we do actually just to continue the conversation on it, and just like the various, inequities? Because right now, I will say, having worked in the field for a while, it seems like now as a, equity strategist, I have less resistance to move forward right now, but hopefully it will continue like that. But just by, things go in cycles, I'm not sure, but what can we do to really keep this in the forefront?
I don't know if you want me to speak to that again.
Yeah, it's okay.
Sure. So how to keep this momentum moving forward? I think the piece that I mentioned on our analysis of the use of the word racism is quite profound and important on this level, that we need to build acceptance for the word as something that we can measure. It's never been published in the Journal of the American Medical Association. Profoundly important social epidemiologist, has revolutionized our understanding of health inequities. And she has never been published, perhaps by self-choice or perhaps by editorial decision. She has never been published in our journal of the American Medical Association. So how do we build space for that kind of work, right? That recognizes the legacy, the history, the process of embodiment, which brings into the fold, right? Deeply complex models of genetic variation, of epigenetic variation in populations, but also the deep structural and political systems that harm populations. I think it behooves all of us in our research and publishing, dissemination worlds to make space for that kind of work and recognize that it would be a loss if we continue to push that aside into other venues.
All right, and I'll ask this question to Mildred. So, what are the particular challenges with research? I mean, you mentioned some during your talk, but are there any other, particular challenges that involves genetics and references to specific groups of people that you maybe did not expound on in your talk?
Yeah, I think, this is the idea that race is not a biological construct is very hard for biological researchers and clinical researchers to wrap their heads around, because that's what we've been taught. We've been taught the opposite our whole lives. So I think that's a major challenge. On the other hand, I think that these discussions around racism, socioeconomics, politics, and other factors that clearly have health and biological effects, I'm hoping that this will open the conversation up to encourage researchers to think more broadly about, going beyond sort of their narrow focus of, genes and biochemistry and things like that, and think about more broadly about sort of health and disease in that way. And also hope that people will take away from these conversations a kind of questioning of the assumptions that we've been taught. The government mandated racial categories and ethnic categories that we use, really make no sense from a scientific perspective. What does Asian mean, right? Like, what does Hispanic mean? It seems obvious to me that these are not meaningful and useful scientific categories when, Asian is potentially representing, 1 billion people with huge variation, and also in a world where we have, huge migration across the world, immigration, and the idea that there are pure categories of anything is just, that's not tenable anymore. So I'm just hoping that these kinds of conversations will encourage scientists to really be more critical of their own work.
Yes. It's interesting that you say that. As you say that, we do have migration across the world, and depending on where you land, you may be a different race. So it's definitely, your race changes per country. that just goes to show that how big of a social construct race is. I do have, let me see if we have any questions from the audience right now. Please drop your questions into the Q&A. We're eager to hear what you have to say and like what you want to ask us. But moving along, what do you think, this is for either Dr. Cho or Dr. DeMaio, what do you think are some particular challenges? What are some red flags that journalists should watch for when reading a study that involves race or ethnicity?
Well, I think, some of the things we've already mentioned are red flags in terms of anytime you see a study that attributes a cause and talks about race or ethnicity as sort of as a cause of disease or a cause of drug response or something that, or even a marker of drug response or treatment variability or anything like that, I think that is a red flag because, you know, as people in public health know, you know, I think there's too much, we're too quick to look at association and think that there's a stronger relationship, like a causal relationship there. So just because, you know, people who are in one category are more likely to get a disease than another doesn't necessarily mean that the fact that they are of a different race is behind that. It could be, you know, many other things.
Yeah, I fully agree. And in many ways, I wonder if journalists are even better equipped than if people in medicine and public health to ask these questions of why these patterns come to be, right? Like the causal patterns at play. You know, we could list hundreds of articles that list race, Black race in particular, as a risk factor for disease, along with tobacco consumption or all kinds of, you know, traditional risk factors that we list race as a risk factor for whatever outcome, whether it's obesity or diabetes or cancer. And equally, we have lots of studies that frame the zip code or the census tract or the community, right, as the driving factor. But there's nothing magical about zip codes, right? Like there's nothing magical about census tracts. They represent the lived experience. They represent systems, political, economic, all kinds of systems that shape lives, right? That shape our ability to live the lives that we value. And I think journalists are really good at asking these questions of why do these patterns take shape? How do they take shape? How have they played out over history? My favorite book in this area is Mama Might Be Better Off Dead, The Failure of Healthcare in Urban America, written by a journalist, Lori Abraham. It was not written by a scientific researcher and academic. It was a journalist who followed a family in North Lawndale, one of our worst off communities, economically speaking, in the shadow of the Illinois Medical District, right? As advanced, as high tech, as remarkable medical infrastructure as one can imagine. And this family was systematically blocked from accessing it until the very end of their lives. And it was a journalist that told that story in profound ways, right? That get us to understand in ways that maybe statistical models never can.
Yeah, and you know, that's one thing I'm going to say this as a former journalist. That is one thing that I did like about being a journalist, where as a scientist, it was like a lot of like quantitative data that was going on. However, when I went into journalism, I was able to, it was more qualitative with even more, I guess, power, because you really get to find out the reasons why things go on. And like usually in, I will say, you know, in research, you know, it is sometimes you're sort of limited, you know, to things that you can ask because you're trying to get, you know, the research question answered. But just as a journalist, having that just opportunity and really privileged to go to do a deeper dive is all, you know, of the best, you know, for that. And if you're a researcher and a journalist, you get the best, you get the best of both worlds. We have had some successes, you know, major successes with addressing racism, you know, in medical research and publishing. I talked about some, and you know, that was really with us, like doing a survey, see who is publishing, you know, within, you know, the journal, and then you two have actually done some written papers on, you know, just about the word racism, as well as what, as Mildred went into detail about just language, you know, that is not defensive. Is there anything else that you wanted to add to that list as it relates to successes of addressing racism in medical research and publishing?
I think the only thing that I would potentially add is I think the recognition among many people that business as usual would be unethical and produce further harm. So Health Affairs has led this charge, and it's remarkable to see this now inspire the reflection in other journals. That's a huge success. And it would be hopefully difficult to go back to the way things were.
And this is a question for journal editors, Mildred. Are there some submissions that maybe we are rejecting today because of racism that would have not been accepted a year or two ago? Put it this way, are we more lenient to, I guess, more open to accept terms about racism, or the research on the intersection of like racism in health or racism in genetics now than we were 2 years ago? Because this is an ever evolving cycle. I just wanted to get your take on that, Mildred.
Yeah, I think so. I think that a lot of journals now are really revisiting kind of their criteria for accepting journals in terms of what kinds of research questions they think are important. And I think addressing broader issues of structural racism sort of have come up to the top of, closer to the top of the list than they were before. And I also think that there's more attention in sort of the reviewing process to also to question sort of things that weren't questioned before, like why are you only using a single population? It might be populations that are very high income, for example, or populations that have only highly educated white participants in the study, and that used to sort of just go unnoticed, but now that gets flagged as maybe this is not, maybe this isn't answering the most important research question.
Right. As it's interesting, as we at Health Affairs sort of will advance equity. People have been sharing different stories with us, particularly as it relates to like our survey, and how sometimes if you don't identify with a certain group, sometimes things go over your head. But I did have an American Indian researcher reach out to me, and she was talking, via the qualitative analysis, and she's doing great research, but she kept getting pinged on her population size was not big enough. And so, she was like, that is the ongoing thing, particularly, with American Indian researchers. And it made me think, when I was, talking, with her, I said, we have built a construct that really cater towards a particular population that we don't even realize how, I guess, unfair and the biases that are associated with it. And that was really, I had many eye-opening points within this job, but that was really one, that really, stuck out, to me. And then just the fact that one of the things that we at Health Affairs have been noticing, we do have an issue coming out on racism in health. And one of the things that we say, if we have racism in health, it's not going to be about comparison of white, Black, and Hispanic, because you see that like a lot. And so we're making sure, because racism in health, we include all, racial groups, particularly those racial groups that are marginalized. That includes, American Indian, the ethnicity of Hispanic, the Asian American Pacific Islander population. And, so it's just very important that when we address racial equity, that we're inclusive even among those groups that have been marginalized. And I would like to add, let me see, we're still waiting on some questions coming in.
I see a few in the Q&A.
Okay.
That I wonder if I might address one of these that is about
please.
disaggregating data, since I mentioned that. And I just want to be clear that I think, when people are sort of confronted with the idea of examining how they use race and ethnicity, people are afraid that that means that they shouldn't use race or ethnicity in their research. And I just want to be clear that that's not what I'm saying at all. That's not what I'm saying. And I'm not saying that disaggregation is the right way to go in anything. What I think I want to convey is this sense that, I think that the way we use race and ethnicity categories has been very much like, well, we'll just use the OMB categories because that's what the government says we're supposed to use, or we'll just use what's in the electronic health record because that's what we have, right? But it really depends on what kinds of research questions you're trying to ask as a researcher, right? If you're trying to address racism and you're trying to understand racism, then using social categories, using self-reported categories, using reports of how people perceive others' race is completely appropriate, or ethnicity, right? But if you're trying to use it as a biological variable, that's where you get into trouble. And so I think you just have to be clear that the variables you use match the research question and the methods that you're using, and that whatever variables you use, that you make some attempt to validate your measure. Like, how accurate is this? How consistent is this? How reproducible is this? Just like you would with any other variable, you need to calibrate it. You wouldn't, use blood pressure readings if, there's a huge variability in your blood pressure readings from day to day. So just treat it like any scientific variable.
Yeah, these are really excellent points. If I can add two things that your comments kind of sparked to me, it also relates to the idea of always looking at the history of the categories that we use, right? To recognize that they have changed over time, that they vary across place. Maybe you mentioned this before. I fill out a different box depending on what country I'm in, right? I was born in Argentina. We don't have a Latino box in Argentina. I studied in the UK. The racial categories there look very, very different than any form that I filled out in Canada or here in Chicago. So just knowing the geopolitical history of the categories that you're using could go a long, long way towards overcoming the thinking that they reflect natural biological differences between groups.
And so with that being said, I guess one of the things that as a journalist, you really have to be careful on where this research is coming from. For those, like as you said, is your different races. I mean, you name 4 countries where they're different, where you might identify as a different race. And now I know, Mildred, you saw a question. I did not see any questions. Did anyone? Do you guys see any more questions?
Yeah. So in the Q&A, I can just throw some of them out there.
Okay.
The first one is about how can medical journalists reframe or better pitch health equity stories when they're faced with pushback from editors or management? Like, this isn't new enough, or our readers aren't interested. I'm actually interested in what you guys think about that as journalists, because yeah, I think that there might be.
Yeah. Actually, do you mind if I take that, Fernando?
Yeah, that's what
okay. All right. Yeah. You know what? So it's interesting that and I think I mentioned this to you Mildred, before in the previous conversation that we had. In some places, diversity of your background, put it this way, whatever we do in life, our background always creeps in. Some type of fashion, in like some type of way, fashion or form, even if we don't want it to actually creep into the scenario. But I discussed with you a story where I had to pitch a article to one of my editors as a journalist, and the only reason, like what made the article his sentiments were first like, well, what's the big idea with this? And so it was an article dealing with a sickle cell trait. I went to this conference for sports directors, and they were talking about, do not let your, they were recommending, do not let your children with sickle cell trait actually play in, Division I football, specifically with that. And so, when I first went there, I wasn't grasping, what they were saying. And the reason why I was not grasping what they were saying was because I was hearing fulminant sickle cell disease and not sickle cell trait. And it was selective hearing because sickle cell trait, as an African American, and it has been told to us that the sickle cell trait doesn't cause that much risk to your life. They just told us, as children and things like that. My parents actually told me things like this, as well as this was pervasive throughout the community, that if you do have the sickle cell trait, just make sure that you're careful if you do marry someone or partner with someone who has the sickle cell trait, because you could have a child who has fulminant sickle cell disease. But they told us that that was the only thing you have to worry about with the sickle cell trait. So when I went to that conference and heard that sickle cell trait was dangerous, it automatically put up my antennas to say, like, oh, this myth that has been going on in the Black community, this notion that has been going on in the Black community is a myth, that the sickle cell trait is not as dangerous. Because for that year, for a decade, from 2000 to 2010, the sickle cell trait was the #1 killer of Division I athletes, and it really didn't get any traction in the news outlet. So I had to explain that when I'm explaining to you why that was important to publish that. And actually, after I explained that, he was a little, hesitant. But when we published it, I mean, it took off. It really took off. Like, we got, responses saying, people, particularly a lot of Black people saying they had no clue, that, it could pose, so much of a threat. Actually, then someone from the NCAA called, because at that time they were considering to really require sickle cell trait testing for all the Division I athletes. Moving it, I guess, 10, 12 years later, it is now required for all, even if you're not Division I. And it actually was used in a hearing, to implement testing, among NCAA. So if that, conference that I went to on a whim, not really expecting to get anything, and end up being one of the stories that still come up today, that I hear today. So just really, pitching, your article and just explaining why, it is important is something that that's we as a journalist, and I say most of the journalists, always a journalist, can do, is just really give the rationale for that. I don't know, Fernando, did you see any questions? Or Mildred, did you see more questions?
There's one about JAMA, saying that JAMA has made recent pledges and actions to reckon with past racism, but some of their actions have been criticized heavily, such as the infamous podcast. And so the question is, what lessons have you learned from these debacles? How do we know what's the right way to take an anti-racist stance?
Yeah, first, huge thanks for that question. And I'll answer it with full transparency, as best as I can for my stance. So first, note that there's fierce editorial independence between JAMA and the American Medical Association. So the team that I sit on at the Center for Health Equity under Dr. Aletha Maybank, it's completely different enterprises. I know that, and we recognize that the public at large doesn't see that division, and that's okay. But it's something that I always do try to explain when I can, that JAMA isn't our shop per se. I think what we've seen though with JAMA, what we've seen with the pushback against our racial justice and health equity plan, which we released earlier this year, the pushback that we've seen in some quarters around our narrative, language, and concepts guide with the AAMC Center for Health Justice, is that this work is not easy, that it will entail a lot of difficult conversations, and it will entail a lot of pushback, right? A lot of criticism, sometimes from progressive actors, sometimes from reactionary status quo defenders. And that, I think, has to be accepted, that there's not going to be an easy linear process for really achieving racial justice and health equity. As a country, this is built into the DNA of this country, right? That it's not the default setting, justice and equity. So any movement towards that is going to be difficult. So I don't know if there are debacles. There have been missteps, of course, that infamous tweet and those things that should not have gone out, that should never have gone out. But they have to be an opportunity to learn, to challenge ourselves to do better, and to hold ourselves accountable for when those things do go wrong, for how the damage could be repaired. So it's not an easy thing, and it's not something that we're going to solve overnight. We're talking about really big questions, right? About addressing racism in medical research and publishing. I can't imagine more difficult conversations and more difficult projects to take on in the United States than the conversations we're having right now. So while I don't have any easy answers, I do convey the authenticity, the humility that our team is bringing to this work, and that we think we're moving towards the right direction.
And we have a question from Anthony Jones. I'm seeing the questions now. It says, definitions are always critical. Is there a clear or concise definition of the word racism that could be broadly utilized by medical research stakeholders? If not, this represents a potential opportunity for today's participants.
Yeah, if I can quickly chime in on that's been a defining feature of much of our work at the MA Center for Health Equity, through the strategic plan for racial justice and health equity and this narrative guide that I mentioned before. We find great value in the work of Dr. Camara Jones, as I know many of you do as well. And she lays out a beautiful, concise, I think very practical definition of racism as a system of structuring opportunity and assigning value based on the social interpretation of how one looks, the thing that we call race. It unfairly disadvantages some individuals and communities, unfairly advantages others, and it saps the strength of the whole society through the waste of human resources. And then she walks through how it operates in 4 different levels: structural, institutional, interpersonal, and internalized. And for us, that framework, right, this idea that it's a system, it's not necessarily the individual behavior, but we're talking about a system. It's based on race, the social construction of race. Very importantly, it disadvantages some and advantages others. That's hugely important, right? And not often recognized. And it saps the strength of the whole society. We all lose, right? And that's what the beauty of Heather McGee's new book, The Sum of Us, that many people are talking about as well, hints at these issues, right? That we all lose from the racism that's embedded in our society, and it operates at these different levels. That's what I would offer.
And for Mildred, I don't know if you want to respond to that question. Okay. All right. And for our final question that we have that: how can journals be accountable for the choices they make in the editorial boards, reviewer pool, and manuscript triaging? Who, besides perhaps the readers, can police journals? Do you mind if I start with that question on the panel? Actually, yeah. So you know, that's a great question. You know, yeah. Who can police journals? So the thing is that I will say, now I'm gonna just speak on behalf of Health Affairs. One of the things that I asked Health Affairs before I did this job, I said, you know, if we're going to do health equity strategy and equity strategy, racial equity strategy, or just equity strategy of anything, is very important that we be transparent. So, you know, I don't know if you guys have been following Health Affairs, but for those who do, at the beginning of the year, January 2021, you know, I said, let's lay out these things. And that was a way of holding us accountable. Because if you put things on, you know, online for the public to see, you will be held publicly accountable to actually do those things. So, it was more I took the approach of like the public policing Health Affairs. People will remind you where you fall short. People will applaud you when you do well, but that's one of the ways that we do it at Health Affairs when it relates to accountability, is just to have that public accountability.
I would agree with that. I think one advantage that publications have is that they're public facing, you know, they publish things. So you can put it all out there and have people throw it back at you when you don't get it right. But I think, you know, one thing I think a lot of these anti-racist efforts have done is to, you know, incent journals and publications to first take the first step in being accountable to themselves by collecting data, as you mentioned, Babe, right? Like most journals didn't even know what their what kind of diversity they had or didn't have, and you have to collect data on it to understand that. So that's the first step, and then making that data public so that you know it's like, you know, sort of the next step, and then acting on it. So, you know, publishing all these things will hold journals accountable for all those things. And then in terms of sort of having an external policing function, I think, you know, there are, you know, one of the things that, you know, Genetics and Medicine, probably other journals are doing, is going back and looking historically over things that were published in the past, searching for things that may have been offensive, searching for, you know, examples of articles that probably shouldn't have been published in the first place. And then, you know, actually highlighting those, pointing to them and saying, look, this was wrong. Shouldn't have done this. We're not going to do this in the future. And, you know, this is why. And again, being transparent about all of that, and making clear statements about the rationale for it.
Yeah, and that's such a profoundly important process, right, of reflection on each journal's history. And it also opens the question that we don't really, right, we've seen remarkable changes with open access journals. We're seeing remarkable changes with preprint servers. You know, we kind of take it as a default that this is the way things are done and how results and findings are shared. But I'm not so sure that in 20 years' time, our publishing infrastructure will be the same as it is now. And so I have hope that it could actually be more transparent as we move forward.
So that is, oh no, go ahead.
I was just going to say that I think the increasing practice of open publishing with, you know, open peer review will let the policing sort of be crowdsourced, right? So anybody can say, look, I'm going to review this in manuscript and I see all kinds of problems with it, and I'm going to put it all out there and I'm going to attach my name to it. So now I'm accountable for that too. So the accountability gets, you know, spread all around.
Oh, this talk was amazing, and even though I was moderating, I was also taking notes here on the side. You know, I really appreciate the Hastings Center for really allowing us to come to this session and share, you know, our perspectives and everything with all the guests who are here today. And I think we have Ashna, who's coming up next, but I would just like to say I was really on behalf of the panel, because I know we have 2 minutes left, on behalf of the panel for Dr. Cho, for Dr. De Mayo, thank you, and we really appreciated this conversation that we had today.
Great. Thank you so much again, everyone, for attending. A recording of this discussion will be available shortly on the Hastings Center's website, www.thehastingscenter.org, and on ELSI Hub, along with resources and recordings of the previous 3 events in the series. We also would like your feedback on today's event. You will receive a brief survey via email shortly after the event. Please return it as soon as possible. We'll use your feedback to improve future events. Thank you again, and have a great rest of your day.